I'm very excited to announce our last plenary session and also to announce a new collaboration for the Society of Academic Emergency Medicine. We have developed a relationship with the Journal of the American Medical Association, JAMA, and this is our first year presenting a plenary abstract that will be released from embargo simultaneously with the presentation. So the following paper has been accepted to JAMA. This is the first notification to the public of that acceptance, and the JAMA website is releasing the announcement as we speak right now. It's been coordinated and timed. I'd like to thank SAEM staff for moving heaven and earth to accommodate this, and I'd like to offer my warmest congratulations and a warm welcome to Brian Driver of Hennepin County Medical Center, who will present Bougie use in emergency airway management, a randomized trial of 757 patients. Brian, please come to the podium.
Okay, good morning. Thank you for having me. Let me see if I can advance the slides here. Okay, got it. Well, I want to, my name is Brian Driver. I'm an emergency physician at Hennepin County Medical Center. I want to thank the program committee for allowing us to present our research. I want to thank my co-investigators and my research coordinators and research associates. The title of our project, you guys already know. We have nothing to disclose. Emergency orotracheal intubation is performed more than 300,000 times per year in the United States. And adverse events are common, estimated to occur in about 1 in 8 intubations. We know from many studies that first attempt success is important to reduce the risk of intubation-associated complications. Yet first attempt success hovers between 85 and 90%, and so that highlights an opportunity for us to be able to improve this. The Bougie is a tracheal tube introducer first described by McIntosh in 1949. And perhaps owing to its smaller diameter, which causes less glottic obscuration, or its easier maneuverability, or the tactile feedback it provides if placement is correct, we know the Bougie is advantageous in patients with poor laryngeal views and for rescue after failed attempts. But despite its utility in patients' with difficult airways, it's used in less than 5% of ED attempts, according to data from a recent NEAR publication. Recent data from our institution, retrospective data, demonstrated that Bougie use was associated with first attempt success. And so we sought to compare first attempt success with the use of a Bougie compared to the tracheal tube and stylet, and hypothesized that first attempt success would be higher in patients with difficult airway characteristics as our primary outcome, and in all patients as a secondary outcome. So we conducted a prospective randomized trial in an urban academic ED where emergency physicians perform all airway management. The majority of intubations are performed by postgraduate year 3 residents and higher who receive extensive training earlier in their residency in both the Bougie and the endotracheal tube. This was approved under waiver of consent by our local IRB. Consecutive adult patients undergoing intubation in the ED with the use of a McIntosh-style laryngoscope were eligible to be enrolled. We excluded prisoners, pregnant women, and those with known distortion of the upper airway anatomy, as we felt it would be unethical to include them and have them possibly be not intubated with a Bougie. We excluded hyperangulated blades, such as the traditional glidescope blade, because Bougie use can be problematic with these blades, and it's more typical to use a rigid steel stylet. Our primary group of interest, those that we thought the Bougie would be most helpful in, are those with difficult airway characteristics, which are anatomic or other features associated with difficulty obtaining an adequate view or passing the tube. These are present in about 60% of ED patients, and these characteristics you can see there, and they were not defined formally. Their presence was determined subjectively by intubating physicians. As you can see, we could not assess for all of those before intubation, so we ended up enrolling patients both with and without difficult airway characteristics. Patients were randomized in a 1-to-1 ratio to have the Bougie or endotracheal tube and stylet for the first attempt. And in an attempt to balance the number of patients with difficult airway characteristics between both groups, we stratified randomization by the presence of obesity or cervical immobilization. When a patient was identified as eligible, a research associate opened the next envelope of the appropriate strata and disclosed the allocation to the treating physician. All other intubation decisions are at the discretion of the intubating physician, including pre-oxygenation, positioning, neuromuscular blockade, choice of laryngoscope, and whether or not to use video laryngoscopy. The Bougie we used is 70 centimeters long, straight, semi-rigid, malleable, and has a coude tip. In both groups, the best possible glottic view was obtained. In the Bougie group, the Bougie was attempted to be passed into the trachea. If successful, an assistant passed an endotracheal tube over the Bougie to the intubator, who advanced it to the desired depth. Then the Bougie and the laryngoscope blade were removed. In the endotracheal tube group, a styleted tube shaped straight to cuff was attempted to be passed into the trachea. Trained research associates prospectively collected data in real time using a stopwatch from the time of enrollment until 1 minute following the end of the first attempt. After the procedure, the intubating physician completed a structured data collection form, and due to the nature of the study, nobody was blinded. The primary outcome was first attempt success, defined as successful endotracheal tube placement with the use of the first device during the first laryngoscope insertion in patients with at least one difficult airway characteristic. Secondary outcomes included first attempt success in all patients and first attempt duration, which was defined as the time elapsed between blade insertion and removal. Because there is no established minimum clinically important difference in first attempt success, we powered our study based on prior data, which suggested that the Bougie use could result in about 9% improvement in first attempt success, which would require 374 patients with a difficult airway characteristic. All analyses were intention to treat, and we analyzed attempt duration using Kaplan-Meier estimates in a Cox proportional hazard model. In total, 757 patients were enrolled, 381 to the Bougie group and 376 to control. Protocol adherence was 98% for the Bougie group and 92% for the control group. The most common difficult airway characteristics were obesity, blood or vomit in the mouth, and cervical spine immobilization. There was no significant difference in pre-oxygenation, positioning, Cormack-Lehane grades achieved with laryngoscopy, or CMAC use, and more than 95% of patients were actually intubated using the CMAC. In the Bougie group, it was more common that the intubating physicians never viewed the video screen. For the primary outcome, first attempt success, and those with any difficult airway characteristics, Bougie use resulted in higher first attempt success, 96% versus 82%. And in all patients, it was 98% versus 87%. This figure displays Kaplan-Meier estimates for first attempt duration for patients with at least one difficult airway characteristic. As you can see, the first attempt duration was shorter with use of a Bougie with a hazard ratio for first attempt success of 1.29. However, these curves cross, indicating that the assumption of proportionality was not upheld. These data highlight that Bougie use resulted in higher first attempt success, which is important because we know that first attempt success results in fewer complications. This indicates that the Bougie could be considered as a primary intubating device rather than for just poor laryngeal views or after intubation attempts fail. A potential criticism of this study is that perhaps intubating physicians were less experienced or less skilled with a tracheal tube and stylet compared to the Bougie. However, the current data compare favorably with recently published literature. Sackles in 2014, describing exclusively video laryngoscopy, described 78% first attempt success for those with difficult airway characteristics, compared to 82% in the current study, and 90% for those without these characteristics, compared to 92% in the current study. Brown et al. And a meta-analysis of 42,000 intubations described first attempt success between 84 and 87%, which compares well with our 87% overall first pass success with an endotracheal tube. These comparisons argue against inferior institutional performance and suggest a true incremental benefit with Bougie use. Additionally, the data suggest that Bougie use is likely easier than the tube and stylet, as evidenced by less video screen usage and a similar or shorter first attempt duration, despite the fact that the Bougie use requires an additional step. Now, these data are from a single institution with familiarity with the Bougie, so these results may not generalize to all institutions, but in our experience training residents, Bougie use is intuitive and quickly learned. We used a single-use straight Bougie, so the results do not generalize to Bougies packaged in a curled position. And furthermore, these results do not generalize to hyperangulated blades like the traditional glide scope. In conclusion, in this emergency department, use of a Bougie compared with an endotracheal tube and stylet resulted in significantly higher first attempt success among patients undergoing emergency endotracheal intubation. However, these findings should be considered provisional until the generalizability is assessed in other institutions and settings.
Wonderful, thank you. Any questions for Dr. Driver? Please.
Relation with this, but have you looked at cricothyrotomy with Bougie use and success rate? Area of thoughts about that as well. I've had just some anecdotal experience, but I haven't seen any literature to confirm that.
Yeah. Obviously, that doesn't pertain to the current study, but Hennepin published something maybe 10 years ago demonstrating faster and higher success rates with Bougie-guided cricothyrotomy compared to the standard technique.
Hi, Rich Hamilton from Drexel. Is there a sweet spot where you can look and decide Bougie or ET with stylet? In other words, have both ready?
You know, that was our current practice at Hennepin, and if you have a grade 1 view, let me see if I can pull it up here. So if you have a grade 1 view, Bougie success is 99% versus 96% with an endotracheal tube. So certainly that's very high for an endotracheal tube. My personal opinion is that there's some value in doing something the same way every time. But there might be a sweet spot where you can pick and choose based on your view.
Wonderful. I'd like to take a moment to recognize Dr. Driver and to once again give a huge round of applause for our 7 plenary speakers. Congratulations to you all.